Thrombus is most certainly a problem. We have manual aspiration, we have mechanical aspiration, and we have some real problems, at least based on some of the data being presented here at ESC. So I am with Sanjit Jolly, who is from McMaster University, Hamilton, Ontario. The results of the taste trial here didn't really mince words. The conclusion was, our findings leave little role for manual thrombus aspiration as a routine adjunct to PCI and STEMI. Where are we right now with this? And then I want to talk about the total trial.
I think we need to be a little cautious with regards to the interpretation of the results. I think actually, as a student of history, you need to look back at previous trials, and you actually look at when was the last trial that was powered for mortality in terms of STEMI. And you have to go back probably about 10, 15 years. The ISIS trial was nearly 20,000 patients, and that was when mortality in STEMI was 12%. So then, you really have to dig down into the New England article and see that, in fact, taste is likely underpowered. It would have shown if there was a large mortality difference, like let's say 50%. But more moderate differences, like 25 or 30%, really the trial was not powered to show such a difference. So when mortality is 3%, I think you need a trial of 25 or 30,000 patients to show differences in mortality. So I think we need to be cautious, and I think the jury is still out yet.
Now, in terms of the total trial, you're the principal investigator for total. It's a large randomized trial of thrombus aspiration. You're enrolling about 6,700 patients.
That's correct.
What are you looking at?
So our primary outcome is a composite of cardiovascular death, MI, cardiogenic shock, and class 4 heart failure. And when we looked at the design, we realized that it really wasn't going to be feasible to do a 30,000 or 40,000 patient trial to look at mortality. And when mortality rates are 3% or 2%, that's really what you need. So we thought, if we can reduce a composite and if we can ensure we're adequately powered, we'll really be able to crack this nut and see if thrombus aspiration improves clinical outcomes.
In terms of what should be done clinically right now, it's obviously going to be a while before total gets underway and published. Right now we have the taste results. Where are we clinically with the use of aspiration?
Yeah, I think the jury is still out. Clinicians, we know from the ACC NDR database, clinicians are using it probably 1 in 4, 1 in 5 cases. They're using it in patients with heavy thrombus burden, and I think they can still go on and use it in that fashion. Total is probably 6 to 9 months away. We're pretty close to finishing recruitment, but the primary outcome is at 6 months. So I think over the next 6 months, while you wait for the results of total, use it when you feel it'll be beneficial in subsets of patients. Outside of a trial, I tend to use it in patients where you've got a large thrombus burden, and it allows you perhaps to use a shorter stent length and prevent no reflow.
Okay, so those are the positions right now as far as what you would recommend for thrombus aspiration.
That's correct, yeah.
And wait about 6 months and we'll have more, I hope.
Exactly.